This week on the BackTable podcast.
This is an excellent tool to treat something that previously was not very easily treated. And it's similar to like the nasal valve. People never looked for the nasal valve until they actually had a treatment for it. And now I do the modified coddle on pretty much every patient to try to find patients that would potentially benefit. And the runny nose patient has always been kind of a patient that nobody wants to see because there's not really therapy for. But now it's a patient that has a pretty good therapy that's an in-office procedure that patients can benefit pretty significantly from. So I think it's an awesome opportunity to introduce this treatment for patients that previously had no significant treatment options.
Hey everybody, welcome to the BackTable ENT podcast. We're a podcast that focuses on all things otolaryngology, and we've got a really great show for you today. Thanks for stopping by. Now a quick word from our sponsor.
Aerin Medical provides ENTs with advanced treatment options that provide lasting relief for patients with chronic nasal conditions. Fitting seamlessly into the office or OR setting, Aerin Medical's portfolio of non-invasive, temperature-controlled radiofrequency products include RhinAer for addressing nasal airway obstruction and RhinAer for chronic rhinitis. Learn more at aerinmedical.com. Now, back to the show.
All right. Hey, everybody. Welcome to the BackTable ENT podcast. My name's Ashley Agan. I'm a general ENT in Dallas, Texas.
And my name is Gopi Shah. I'm a pediatric ENT. How are you doing today, Ash?
Bonjour, Gopi.
bonjour.
Excited to be across the mic from you today.
I know,
and excited for our guest. It's timely to talk about rhinitis because I'm quite rhinitis-y today. So
are you feeling
it's fitting. Taking some notes for myself.
The drip, maybe a clog, I don't know. Well, we have an awesome guest today. We have Dr. Stan McClurg. Dr. McClurg is a rhinologist practicing in Kansas City, Missouri at Ascentist Healthcare. He performs sinus and skull-base surgery in the OR, as well as awake in-office sinus surgeries and procedures. And he's here today to talk to us about chronic rhinitis. Welcome to the show, Stan.
Hey, thanks for having me. I might talk about chronic rhinitis as well.
I was hoping we were going to get that part deleted, edited, but now we'll just keep it in. We'll keep it in.
It's that French. It's those French classes kicking in.
Right.
You gotta get that.
I don't have my chest set up in the background this morning.
Oh, you mean
you do,
like
Stan,
that?
So I don't have that. Yeah. Get those extra vibes to my brain. So tell us a little bit about yourself, Stan.
Yeah, so I am originally from Paola, Kansas. It's a small town just south of Kansas City. I then went and did a chemical engineering bachelor program at K-State, Kansas State University. I then went to KU Med for medical school, where I met my wife, who is actually a OB-GYN at KU. She's the program director there. She'll be happy that I mentioned that. And then we both went to the Ohio State University for residency.
Oh, that's where my husband's from, Columbus.
Oh, yeah?
Yeah.
That was a great time. Yeah. And I actually, once you graduate there, you have to stay or they will actually fire you. So,
Well, once you marry into the family, you got to say the as well. So I get it.
After that, I went to UNC in Chapel Hill and did a rhinology and skull-base fellowship there. Afterwards, I moved back to Kansas City, and I am now part of a practice, Ascentist Healthcare, where we actually have 34 physicians in our group, and 13 of those are ENTs, and I'm the sole rhinologist for them. So it's a great practice. I love being in private practice, and love even more being a rhinologist in private practice.
Awesome.
UNC's a rhinology powerhouse. That's pretty awesome.
Yes, they are. Yeah.
I used to read a lot of Dr. Zanetian's papers on all the pediatric skull-base stuff and the measurements. And so I didn't know him personally, but I met him once and I was like, I've read all your papers.
Yeah. I probably did some of those measurements myself at some point as well. So you're welcome.
Yeah. And then I got to work a little bit with Dr. Senior and Dr. Kimple on the recent CF guidelines. And
both, both amazing
They
people.
were great. Yeah, they were great. But anyways, so shout out to the program there.
Yeah.
Well, awesome. So you're going to talk to us today. We're going to kind of focus the conversation on chronic rhinitis. And so just to kind of kick things off, maybe we can just kind of talk about what this looks like when these patients are, coming to your practice and, what symptoms there are and, what questions you're asking, that sort of thing.
Yeah, so I've actually found that the type of patients that are presenting with this has kind of shifted. Initially, it was patients that presented after everything else had been fixed. So like a patient with chronic sinus infection or allergies or something else, we'd fix all the other issues and then they'd still have this kind of pesky runny nose or postnasal drip. So then we'd just throw ipratropium and bromide at it and be done with it. And there's so many patients out there that have that issue, but they just they just refilled every year and they continued with their Atrovent nasal spray, but there was no other treatments for them. So that was kind of the initial patients that I was seeing and potentially doing procedures on. And then more recently, I've actually been getting patients sent directly to me for chronic rhinitis or postnasal drip. It's, through word of mouth and a little bit of advertising and just people finding out that there is actually a treatment for chronic runny nose and postnasal drip, that I'm getting people that present pretty much entirely just for that, are already telling me what procedure they want done on them.
Mm-hmm. Yeah.
Did the ipratropium work on a lot of the patients?
So it actually works pretty well. Interesting fact, there's actually 2 different strengths out there. The normal one is the 0.06%, and then there's also a 0.03%. Some people are super sensitive. It can sometimes cause dry mouth and or potentially even dry eye when you do the nasal spray, or people will complain that it dries them out too much. But interestingly, and I'll probably talk about this a little later, but I actually use that as a criteria to see if they'll benefit from an in-office procedure such as RhinAer. If they respond to those nasal sprays, I find that they have a much higher likelihood of responding to the procedures.
And these are patients that are, have a runny nose, but that maybe do have allergies or don't have allergies, or how do you think of it as you're categorizing patients? Because when I think rhinitis, it's like inflammation in the nose, right? Like from all causes maybe. And then you kind of divvy it out from there.
Yeah. So actually the definition of chronic rhinitis is constant runny nose for greater than 4 weeks. So it can be from multiple different sources. One study showed that of the patients that have chronic rhinitis, about 43% have allergic rhinitis, and then non-allergics about 23%, and then there's a mixed varietal in there of about 34%. So initially, as I was working these patients up, I wasn't really thinking of allergic rhinitis as a potential patient that could be fixed with a procedure like this. So I was kind of filtering out all the allergy patients and sending them off to allergy. But more recently, I found out that you can actually treat the allergic rhinitis patients with a procedure like this as well. So you don't really have to filter all of them out. But it's nice to do a little initial workup to try to find which category they're in. If they're a chronic rhinitis, not a non-allergic or a mixed rhinitis, then get allergy testing to try to figure out what allergic component they have.
Do all the people with chronic rhinitis, not all the people, I guess, what percent also just have a clogged nose too? Do those go hand in hand, or is this just you've already helped them open their, it's not a blockage, but it's just they're runny?
Yeah, I would say probably about half and half. Probably about 50% of patients will present and say, I have a runny nose, but I also have nasal obstruction. But then there's these other patients, about half of them, that say, I only have a runny nose, I can breathe fine. And I found that kind of the older patient, the classic old lady with the tissue in her hand that goes through 5 boxes of Kleenex a day, that's the patient that usually doesn't complain of nasal obstruction. It's more just the chronic runny nose. And I think, when they're at the bridge club, they all have tissues in their hands, so that they think it's normal.
It's normal.
Yeah.
So what about you have your patients who have like a vasomotor rhinitis picture where it's like they have, runny nose when they eat or something
Or
where
exercise.
it's like like where it's specific, like situational. Are those patients, do you think about them differently? Or are they still kind of, managed in a similar way? Are they still potentially candidates for procedures and things like that?
Yeah, so vasomotor rhinitis, I think, is a different animal. I usually give patients the ipratropium bromide to try out, and it really depends on how significant their problems are. Frequently, it's mixed, where they have a baseline fairly runny nose, and then it's just worse when they eat or something like that. So I kind of leave it up to the patients on whether or not, some people will say, oh, I just use the nasal spray before I go out on a date so that my nose doesn't run in front of my date. And otherwise they tolerate it and manage it fine. But I feel like it depends on how much of a burden it is. And it's kind of a gradient as to how much chronic rhinitis versus vasomotor rhinitis they have.
Yeah, that makes sense. And as far as choosing I guess before choosing the medical therapies, when you're doing your allergy testing, do you have a preference on whether it's, skin testing or in vitro testing?
I usually prefer skin testing. I think it's more sensitive and you can find a little bit more specifics on what types of allergens the patient have. And you can follow it up with intradermal testing in that scenario as well. Mm-hmm. But, for some people that potentially can't do skin testing, then I think that in vitro testing is fine.
What do you think about patients who have negative allergy testing, but they come to you and have, seasonal variations in their runny nose?
Yeah, I treat them just like they have allergic rhinitis. I mean, if it's seasonal, there's something out there that they just weren't tested for, or they had a negative test at that time. But I treat them with the same, intranasal steroids and possibly azolastine if they need that. And it's kind of it's a difficult thing to say. Yeah, you've been diagnosed with non-allergic rhinitis, but you do have an allergy out there, so we're going to treat you like you have allergies. It's just kind of a difficult scenario sometimes.
Yeah, I think sometimes patients have trouble wrapping their head around that because they're like, wait a minute, because sometimes, because the treatment can be so similar, sometimes I'll slip up and be like, yeah, and how have your allergies been, and they'll remind me, be like, remember, I don't have allergies because I tested negative. Right. But it's like, right. I'm like, well, yes, but we're managing you with Flonase and Azolastine and that sort of thing. So it can be kind of tricky.
So potentially, I mean, those patients would actually be pretty good candidates for an in-office procedure because they don't have the option to get allergy shots or sublingual immunotherapy. So some of the more recent studies have shown that patients with allergic rhinitis have a similar benefit to patients with just chronic rhinitis, runny nose, to these procedures. So those are actually probably people you should be talking to about potentially doing a procedure like this.
Okay.
I was just going to say one last question in terms of that initial patient coming to your clinic. Sometimes I feel like the chronic rhinitis diagnosis can be difficult to make in terms of teasing it out from CRS or, because we said it could be 4 weeks. Maybe it's just a subacute sinus infection or something like that. Do you have ways where you clinically kind of say, nope, this is just rhinitis. This isn't necessarily something else going on? Or is that kind of after your exam? Because sometimes the rhinitis diagnosis, not to say it's an exclusionary diagnosis, but because rhinorrhea can be part of, or postnasal drainage can be part of so many other things.
Yeah, postnasal drip is a tough one, but I think the scope is key. I mean, when you do the rigid nasal endoscopy initially, I use a 3 millimeter 30-degree endoscope, and you can see pretty much everywhere up there. You're looking for any purulence, polyps, or anything like that. And sometimes you can see, clear rhinorrhea or other findings that could kind of help you make the diagnosis. But quite honestly, most patients that have chronic rhinitis only, they'll tell you that they don't get sinus infections. Like it's just a constant runny nose that never goes away and it never fluctuates. They never get facial pressure, pain, or color. And color drainage, I think, is one of the highlights is, when people say, I have postnasal drip, I always ask them, what color is it? A lot of people will laugh and say, I never look at it. And then I say, well, you should consider it. looking at your snot every once in a while. But the people that have chronic rhinitis, they'll say it's always clear, whether it's thick or thin or other, but it never has purulence or yellow green color to it.
Because if it did, you would be more concerned that there is sinus infections or
Correct,
some sort of actual infectious process.
Yeah, and I'm getting CT scans on most patients as well that have those type of presentations. So that'll help me rule out any chronic mucosal inflammation as well.
And do you spray, decongest the nose before you take a look, or do you never decongest to take a look, or what's your thoughts on that?
I used to spray everybody, but then when COVID hit, I stopped just because, I was terrified of mucosal atomization of the COVID virus. So I stopped spraying, but I still needed to scope. And I found that patients really didn't have any change on whether or not they could tolerate the scope or not. So I think the key is actually using a small endoscope. So I use the pediatric, the 3 millimeter, and I equate it to a game of Operation that we used to play as children. If you don't touch the sides and they don't feel it and it doesn't go buzz. So I have stopped spraying patients for pretty much all endoscopies other than post-op debridements. And also, when you don't spray them, they don't have the throat numbness and the taste and all that stuff that they frequently complain about.
Yeah, it's true. I feel like some patients complain more about the spray than they do about the scope.
Yeah. I think it's different with the flexible because the flexible, you kind of bump into a lot of things when you're doing that. But the rigid, I think you have a lot more control over.
Yeah. And kids, I feel like the spray could sometimes set you back 10 steps because just to get the spray close to the nose and to take a look is in itself can be. And then they complain, like Ash said, like you guys said, the taste and that numbness feeling. And then by the time you're like, I actually need to get my exam now, it's like, are we game over yet? Have I bumped into the sides of the operation? The operation hasn't buzzed. Right. So...
Before we move on too far, I did want to kind of, you mentioned the postnasal drainage patients, and I do think that is a tricky group because, if the complaint is postnasal drainage and when you scope them, you don't necessarily see thick drainage kind of coming back from the nose into the throat. What do you make of that? And they deny reflux and they say, no, it's coming down. I can, I know that I can feel it. It's coming down from my nose and it drips all day. And at night I feel it and it drips down. It makes me cough and it wakes me up. How do you kind of take that apart and figure out what's going on?
Yeah, it's a very frustrating patient. The postnasal drip can come from about 1,000 different sources. So you kind of have to delineate where it's coming from. I tell patients the back of the throat is very difficult at figuring out where mucus is coming from, unless you have anatomical knowledge like the three of us. But doing reflux treatment potentially and trial there to see if it improves. I'll do a ipratropium bromide challenge for them. So if they are definitive it's coming from their nose, then I'll do a 1-month trial of 0.06% ipratropium bromide just to see if it benefits them and then see them back in a month. If it doesn't, then I basically tell them it's most likely not going to benefit from a procedure and it's probably not coming from your nose. So we can, send them off to laryngology to see if there's potentially a vocal cord issue with a polyp or a nodule or untreated reflux, silent reflux, something like that. And allergies can also potentially do it as well, but it's a little bit longer route to work up the isolated postnasal drip patient.
Mm-hmm. And with your ipratropium challenge, you choose that nasal spray as opposed to, Flonase or azolastine or some other nasal spray because it's an anticholinergic and it simulates what would happen if you ablated those nerves. Or tell me more about that.
Yeah, so it actually kind of recreates what we would potentially do with a procedure such as RhinAer or Clarifix. It specifically isolates the posterior nasal nerve as an anticholinergic to decrease mucus production and some nasal congestion within the nose. So other nasal sprays don't really do that. And luckily, ipratropium bromide is generic, so it's pretty cheap. So what I find is that people that respond to the ipratropium bromide, even just a little response, or it goes away in an hour or something like that, but they do have a response, I find that they have a much higher likelihood of RhinAer working on them. What I usually tell them is, for patients that respond to ipratropium bromide, they'll have about an 80% chance of improvement with a procedure such as RhinAer. And of that, they'll improve anywhere from 60 to 100%. However, if they don't respond to ipratropium bromide and they're dedicated, this is coming from their nose, it drops down to about a 40 to 60% improvement with a RhinAer. So it's not zero, but it helps me kind of set expectations for patients on if we were to do a procedure, what kind of a potential response they would have. And that's actually it's a change in mindset of a lot of surgeons. So a lot of surgeons will say, I'm only going to do a procedure if it's going to fix it 100%, septal deviation or removal of polyp or something like that. And we kind of gauge ourselves on, did we fix the problem or did we not? And when you start dealing with chronic rhinitis and these in-office procedures, you have to be okay that treating something very good is enough. And that's the end result, is that you're going to help it get better. It may not be 100%, but you're going to actually make things better. So it's a change in mindset and thinking of the surgeon.
That's a good point, because some of it's what we're doing is quality of life,
Yeah.
And if we can make the quality of life better, and it's not like you have an alternative to, quote, fix it. So it is an improvement, which is good.
Right. And, we used to do video neurectomies for patients for this, and I've done a couple of those in my life, and the dry eye that you get from hitting the branch to the lacrimal nerve it can be debilitating for patients. It gives them something else to complain about, but it's a tough surgery, and it can be potentially pretty detrimental to the patient.
So I think this is probably a good segue to start kind of talking about these procedures that we have available now to be able to offer patients who, like you said, have tried the ipratropium bromide and it works. And now they're like, wow, this works, but I sure would love to not have to give this to myself 3 times a day or 4 times a day. Or, the frequent dosing can be difficult. So can you talk about the different options that we have now?
Yeah, so the first product out there was Clarifix, which uses cryoablation to freeze the posterior nasal nerve. And it works pretty well. I did start using that initially, and I had decent results. However, the post-treatment headache, the ice cream headache, it's significant. They quote at about 17%, but I find it's more like 40. So I'd have to prepare patients for that, and it also they form a crust at the very back of in the sphenopalatine region where you do the treatment, and that crust can sometimes cause postnasal drip and postnasal drainage as it's healing. So it's actually causing a different source for the problem that you're trying to treat. But more recently, the RhinAer has come out, and it uses radiofrequency ablation to treat the nerve a little bit more aggressively. In my hands. So I find that you actually get a little bit better results with the RhinAer because you're treating the nerve in multiple different spots, and you can also treat the inferior turbinate itself, which the Clarifix you weren't really able to. So I find that you get more bang for your buck, and patients actually have better responses with the RhinAer.
And what is your protocol or your kind of pathway to saying, okay, this is a good option. Let's talk about moving forward with that. Is it, what is your trial? You do just a month of the ipratropium, and then it's like, okay, this potentially is an option, or does it matter if other things are going on, or, what is your kind of assessment, especially for those patients who come in and already know that they want it. And they're like, I'm here for the RhinAer procedure.
Yeah, so I think it kind of falls into the two different categories. The people that respond really well, and that's usually a slam dunk, and they're willing to do it. I'm willing to do it, and also stepping back a little bit, you have to assess the patient with a scope to make sure they're a good candidate. If they have a horrible septal deviation and you feel like you can't get to the location you need to in the like the sphenopalatine region at the posterior attachment of the middle turbinate, they may not be a candidate for anything unless you take them to the operating room. But for patients that have good anatomy and have good response, I think those patients, all of them, will probably end up getting a procedure like this. The patients that don't have great response and or have bad anatomy, we have to talk about the pros and cons of, if we try this procedure, there's a possibility that I can't get back to where I need to. There's also a possibility that, it's not going to fix your problem. However, we're at the end of the line here for your issue. So there's no other steps. And this step of RhinAer, it's not going to burn a bridge. It's not going to, recovery is minimal. So if you want to try this procedure, I'm happy to do it. We just have to kind of set our expectations that there's a possibility it might not fix your problem, but there's no other steps. So if you want to do something, this is it. Does that make sense?
Yeah.
Yeah.
You said that it can also address the turbinate a little bit. So explain to me, so you're going in, you have a wand or a paddle, right? The handpiece.
It's a stylus. Yeah.
A stylus, okay.
Yeah.
And then you're putting it, as you said, kind of right below the posterior attachment of the middle turbinate, where the nerve would be. And then you said 3 places. So kind of, can you describe to me in detail sort of where, and then you said you're addressing the turbinate, so does it also shrink the turbinate? And are you just putting it on top of the mucosa?
Yeah, so there's actually a newer stylus that came out, the RhinAer 2.0. It has an offset to it. So it's not just flat at the end. It actually kind of tilts back a little bit. So it'll fit into the sphenopalatine region just at the attachment of the posterior middle turbinate pretty well. So you start there. And it's also the tip of the stylus is a little bit smaller, so it fits a little bit easier back there. So you start there, you do, I usually typically do, 3 to 5 treatments, just kind of walking anterior as you do it, and then step down and kind of walking anterior as you're doing that. And then you follow it down to the posterior aspect of the inferior turbinate, and you can actually do some treatments on the inferior turbinate as you come out. So the newer wand, you can do a total of 22 treatments. So that's kind of the max. So you could do 11 on each side. And some people will actually treat the inferior turbinate because it does shrink it back, so it can allow you to visualize and find the posterior nasal nerve site a little bit better. So you could treat that inferior turbinate initially, and I'll do that sometimes, to actually see the posterior nasal nerve area a little bit better. And the cool thing about this is that there's no incisions, so minimal bleeding from this. You're just kind of pushing tissue out of the way, and it helps the patients with nasal obstruction because you're actually reducing the inferior turbinate, and also helps with visualization during the procedure.
So can you talk about your clinic setup and, maybe a little bit about your anesthesia protocol and how you kind of get these patients ready for the procedure in the office?
When I first started doing procedures in the office, I actually started with inferior turbinate reduction, submucous resection of inferior turbinates, which I never really learned in residency or fellowship. I just kind of made up, and it went really, really well. You're actually causing, you're using the submucous, the microdebrider blade to remove some tissue, so you have a little bit of bleeding. Then I stepped up to doing in-office sinus surgeries, which I still do occasionally. And I would do all of those procedures in my procedure room. Then my next step was actually using, treating the nasal valve with RhinAer and using that instead of submucous resection for inferior turbinates, because I get pretty good results with minimal bleeding for that. And then that kind of segued into doing Clarifix and or RhinAer. And I actually now do those procedures just in the regular exam room. For multiple reasons. It's a fairly easy procedure. Patients are comfortable with it. They've already been there with their initial assessment, and it really helps with the flow of my day. So I'm not using up a dedicated procedure time or a dedicated procedure room. It's just kind of fit into the day. And I've trained my office staff. My medical assistant will actually do the initial application of the tetracaine Aerin pledgets. So they'll do that, let them sit for 15 to 20 minutes. And then when I go in, I do my injection and I use just straight up lidocaine. So I do not use epinephrine in this because it causes the tachycardia and anxiety, and you really don't need it because it doesn't bleed very much. I use a RAN needle. I don't know if you're familiar with a reinforced anesthetic needle. It's a very long needle. It's a 27 gauge tip with like a outer sheath on it. So when you do the injection, it doesn't spray as much of the lidocaine down posterior oropharynx and nasopharynx. So I bend that even more than the initial bend to actually get to the location.
Wow. And that injection, is that just right at the location, just one spot right where you are going to treat, and then it kind of blanches and, goes to that whole area, or do you do more than one poke? And then
I usually do one or two, depending on, I want to see that the blanching. So the bleb is important. It helps with the conduction of the energy for the RhinAer wand itself. So you want to see that. And it also helps with, of course, patient tolerance of the procedure. So if I don't get it well on the first one, then I'll do a second one. I will also mention that injection can be kind of hard. So for some, people that maybe aren't comfortable doing those injections, I usually recommend that they start trying it in the operating room, when they're doing sinus surgery. It's a little bit hard to hold that needle in the correct location to actually insert it and not run into everything. You don't want to do that while a patient's awake. So do it while they're asleep, practice it so you can get to the correct spot to do those injections.
Yeah, that's good advice. And it's even harder with a spinal needle compared to the RAN needle. I mean, the RAN needle does help a lot because it's more rigid. It doesn't flop around in the nose as much. Are your pledgets, what percent is it separate solutions of Aerin and tetracaine, or you have a compounded Aerin tetracaine gel, or what's actually on your pledgets?
So I just use a 50-50 mix of 4% tetracaine and Aerin. You want to make sure you wring those out. So if you don't, then they get the horrible throat numbness and they start clearing the throat and coughing. It's just miserable. So make sure you wring them out really well. And as I put them in, I've actually taught my medical assistants this too, is you kind of bend the very distal portion of the pledget to try to sneak it up into the middle meatus as you put it in. It's not 100% effective, but as you do that, if you bend it laterally, it'll actually sneak up into the location where you're trying to get to a little bit easier. Mm-hmm. And I do 2 of them, let them sit for 15 to 20 minutes. Yeah.
Okay.
Yeah.
And you keep your patients, do you keep your patients sitting up?
Yeah, it's they're mostly sitting up, not laying flat. That's how I scope patients, and that's kind of my setup in the office. So
I was just going to say your pledgets are your standard sinus pledgets with the strings that you use for sinus surgery.
Yep.
And the RhinAer device, it's using the same console as the Vivere, right?
Correct. Yep.
But it's different though. Like, so when you plug it in, the machine knows that this is for RhinAer, and when you hit the pedal, it's doing the time cycle that you would for RhinAer and the amount of energy. Yeah.
So when you plug it in, there's actually like a microchip in the cord itself that will tell it whether it's a RhinAer or a Vivere. And the RhinAer is just 12-second treatments. So when you're doing the treatment, it goes very rapidly, and it goes up to, I think, 61 degrees Celsius. So it's temperature controlled, so it doesn't get extremely hot back there. But it's the same unit. So if people are doing Vivere in the office, it's very easy to incorporate the RhinAer as well, because you just need to buy the separate stylus and plug it into the same unit.
But you would never use the like if you were out of one stylus, you would never use the other stylus just in a different location, because it is a different amount of energy and a different time cycle and all those things, right?
Yeah, and it's also different size. I mean, the length of the Vivere is not far enough to get back to the location that you need to get to. And the newer wand, the RhinAer 2.0, you can actually bend it a little bit easier, and it fits fits better posteriorly with the smaller diameter of the shaft as well.
Anything else for the procedure part of it before we move on to kind of post-op care?
I was kind of mentioning previously how I'll do the initial endoscopy to see if patients are going to be a good candidate based on anatomy. With the more recent changes that they made with the new wand, I'm actually finding that I can sneak this newer one into more smaller areas at the back of the nose. So if they have like a large posterior spur or even a significant septal deviation, just because of the size of this new one, you can actually get in there and treat the location you want to. So I'm doing more and more procedures that previously maybe I couldn't because I couldn't get the wand to the correct location.
Mm-hmm. And do you use a pediatric 30-degree rigid scope for these as well?
I actually use a 0 for these because, I like to have the light cord going off towards me, and the 0 you can do that. 30 you can't really do that. Yeah,
makes sense. Yeah. Oh, and can you do this in the operating room, or do you like for your patients who you just maybe, or every now and then you have a patient that's like, put me out. You can't. I can't even have a scope. Like you're gonna have to knock me out.
Yeah, I do these procedures in the operating room as well, and for the people that potentially might need a septoplasty to gain access, I'll do it in those scenarios. I've also been doing. Like some of the other patients and from other ENTs in my group have caught wind of this procedure, like with pamphlets or whatever. So I'll actually do combination procedures. So like if they're getting like a rhinoplasty or something, but they also have post-nasal drip, I'll just jump in and do a RhinAer right before they get their rhinoplasty. So it's a good adjunct for other procedures as well.
Mm-hmm. Yeah, I wonder if the tracked balloon would help with your deviated patients. Like I've used it for, it's like are you familiar with it? It's an McClurg balloon that kind of helps kind of push things out of the way. I've used it for my like eustachian tube dilation patients where they have like a spur or a deviation to that side, and I need to get back to the nasopharynx and I can't. So along the floor of the nose, of course, there's quite a bit of like inferior turbinate out fracture that happens as well as kind of pushing that septum over. But I wonder if it would help you gain access for this. I mean, it's a little bit higher up in a slightly different location, but I don't know, something to think about for your office patients.
I think it probably could. The only issue I have with that is when you push it from one side, it goes to the other side. So you potentially can cause a nasal obstruction on the opposite side of where you're doing the track balloon. So I think it would probably help gain access.
What's your post-op? Do they need to be doing any saline, or is there any post-op care and then sort of, that immediate, post-op stuff, and then how long it lasts for, that kind of stuff?
So actually one of the cool things about this is there's minimal post-op care necessary.
They don't have to do saline? Come on.
I mean,
Stan, you're a rhinologist. Everybody does saline afterwards.
Yes, they have to do saline. I tell them they can if they want to, but
it doesn't. That's not something they need.
I don't think it really helps, other than getting the a little bit of the blood that might have occurred from the procedure. You can do it for the first couple of days. I will sometimes send them home with some Aerin nasal spray just in case they have a nosebleed. There's always that concern that you could cause a bleed from this venopalatine artery or something like that, but I've never actually seen that myself. I did take care of a patient that maybe someone else did, but I didn't cause it myself. I usually see patients about a month out afterwards, and one of the things we talk about is how for whatever reason it sometimes takes a little while for them to have a significant response from this procedure. So I'll see them about a month out, and usually at that point, if they're going to have a good response, it's actually kind of fluctuating. So they'll have one day that's good, one day that's bad, and then kind of alternate. And I'll talk to them about how that's actually a good response. And usually at about 2 months or so, they'll notice that there's even more improvement. And that's happened for most of my patients, is it'll kind of fluctuate initially and then get better after about 6 to 8 weeks. And I also find that in that interim, they can use the ipratropium bromide as well. And the combination of the RhinAer plus the ipratropium bromide usually works very effectively. So maybe they only have to use it like once a day, or when they use it, it lasts for much longer than it previously did.
And at what point do you tell them, okay, this is as good as it is going to get, and this is kind of the final outcome we can expect?
So for most patients, I'll just see them at about 1 month and then potentially see them at 2 months if there's any concerns. And I usually tell them by about 3 to 4 months, that's usually the kind of end result that they're going to be getting. Quite honestly, I just don't see patients back after that very frequently, just because I think they're happy and they don't really need any further treatment. There's been some studies showing that this treatment lasts at least 2 years. It's only been out for a little bit longer than that, so the studies are ongoing. Similar to like Vivair, that they keep on coming out with a new study every year to show that it's still working. And currently it's about 4 years out. So I think they'll probably continue to do that, but it has been shown that it has long lasting results. And then at the same time, say 10, 20 years down the road, it comes back. They realize how easy this procedure is and they'll just come back and we'll get a touch up. So,
So have you had to do any revisions yet, or is that just so rare?
I've had to do a couple revisions on the Clarifix, and what I've actually done is transitioned over to doing the RhinAer on those patients just to kind of switch it up. But usually what happens is they'll have a really good response, and most of them have then subsequently gotten COVID for whatever reason, and then it like just totally screws up their posterior nasal nerve, and they start having runny nose again. So I can't really explain the pathophysiology of that, but I've had probably about 5 patients in that scenario. We just do it again and it works the second time as well.
So they were doing well and then they got COVID and then their nose started running like before. And then you do it, you repeat the procedure and then they're good again.
Yeah. And I'm not going to do a study on that. I really don't want to. But
you don't want to be the expert for
get the on the
for COVID rhinitis. No.
One question for you. So we talked about how with the device you can address the rhinitis with a postnasal nerve, but you also said, hey, you can kind of reduce some of the posterior inferior turbinate with it as well.
Yeah.
Does that, so for the patients that have significant nasal obstruction with the rhinitis and they have, big inferior turbinates, can you just then use the wand and bring it interior with the 11 options that you have? Or are there patients where you're like, hey, I need to actually do something more, I don't know if you want to say more, or a different device that's more specific for inferior turbinate reduction? I guess my question is the device like an adjunct to kind of give you a little bit of, or does it actually also do turbinate reduction as well?
So initially, when I was doing these procedures, I would do like a submucous resection as well, as for those patients that have inferior turbinate hypertrophy as well as the chronic rhinitis. But then I realized that the RhinAer wand itself actually does a pretty good reduction, and you can use the multiple treatments along the entire length of the inferior turbinate. It zaps it pretty good, and post-operatively, I have difficulty finding difference between the patients that I did the submucous resection versus the RhinAer wand itself. And then you're actually just using the same wand, so you don't have to open up a second one and eat that cost. So I would say if patients have continued nasal obstruction afterwards, you could offer them a submucous resection as well, but I haven't ran into that scenario, quite honestly.
And this could potentially be for your allergic rhinitis patients as well.
That's actually one of the interesting scenarios. Is I started doing this for the chronic rhinitis patient that maybe was non-allergic, but more recently I've been adding on this as an adjunct for allergy patients. So even if they test positive with skin testing, I give this as an option for maybe a little bit more immediate relief of some of their symptoms, the nasal obstruction, the runny nose. And I've had quite a few patients that are interested in doing this because they don't want to wait the 6 to 12 months for their shots to start working. So it's kind of like a jump start to getting their allergy therapy ramped up a little quicker. And it also opens up this entirely new avenue of patients. So like all those patients that we previously dumped into the allergy bucket that we very rarely see, they just see their allergist or your allergy nurses. You could actually send this out as an option for those patients themselves and get those patients back in to potentially do a procedure on. So it could potentially open up a pretty large volume of patients to be seen.
Does it last the same amount of time, you think, in terms of, does it help for the same amount of time as for the 2 years, potentially, as your non-allergic rhinitis?
I would actually think it would probably potentially last longer just because you're also doing allergy therapy at the same time. So I just think that it ramps things up a little quicker and patients get a more immediate response, and then they have subsequent allergy therapy that's treating their ongoing symptoms. So
yeah, that's very interesting. As we kind of wrap things up, any final thoughts or pearls that you want to leave our listeners?
This is an excellent tool to treat something that previously was not very easily treated. And it's similar to like the nasal valve. People never looked for the nasal valve until they actually had a treatment for it. And now I do the modified coddle on pretty much every patient to try to find patients that would potentially benefit. And the runny nose patient has always been kind of a patient that nobody wants to see because there's not really therapy for. But now it's a patient that has a pretty good therapy that's an in-office procedure that patients can benefit pretty significantly from. So I think it's an awesome opportunity to introduce this treatment for patients that previously had no significant treatment options.
Yeah, it's exciting to be able to have something to offer for sure.
Yeah.
Well, thank you so much for coming on the show, Stan. If our listeners wanted to contact you, reach out to you for any other questions, are you on social media or website or anything like that?
Yeah, so I have a Facebook page, Kansas City Sinus, or you can reach out to me just through my website, or I'm happy to talk to anybody that's referred through you guys, or the local Aerin rep usually can reach me and get a hold of me if there's any questions.
Awesome. Sounds great. Thanks for taking the time. It was fun.
Thank you, Stan.
Yeah, thank you. It's been great.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff. Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Thanks again for listening, and see you next week.